Without further ado, I would like to welcome our first keynote speakers of the day, Robyn Goldberg and Greta Angert. Angert. Sorry. Their presentation, I'm over my head when to tell clients I don't work with eating disorders. I had a coaching client a few years ago who was anorexic, bipolar. I was over my head. I don't work with eating disorders. Take it away. You're going to introduce yourself.
Yeah. Oh, I thought you were reading.
No.
We sent you our bios.
Yeah.
Yes.
Oh, sorry.
Thank you. That's okay. Thank you.
Sorry? So Robyn Goldberg, RDN, CEDRD-S, began her career at Cedars-Sinai's Medical Center in Los Angeles as the inpatient dietitian in the Department of Cardiology. Over the last 25 years, she has developed her own private practice in Los Angeles, where she specializes in medical conditions, disordered eating, eating disorders, health at every size, pre-pregnancy nutrition, and people in recovery. She is a certified eating disorders registered dietitian and supervisor from the IADEP, as well as a certified intuitive eating counselor. For the last 8 years, Robyn was the nutrition counselor for the Susan Crevoy Eating Disorders Program at the Wright Institute, led eating disorder and body image groups at various sober livings in Los Angeles. She is a contributing author and a nationally and internationally known registered dietitian nutritionist. Robyn is the author of the new book, The Eating Disorder Trap, A Guide for Clinicians and Loved Ones, co-author of an online course, Your Recovery Resource, and the host of the podcast, The Eating Disorder Trap Podcast. Greta Angert, MS, LMFT. Did I say that right that time? Say that, say Angert. But you're not Angert. No. Now I'll remember. She's not Angert. She's Greta Angert. MS, LMFT is a psychotherapist, eating disorder consultant, trauma EMDR specialist, and MFT intern supervisor. She received a bachelor's degree from Columbia University and a I just got the chills. And a master's degree in counseling psychology from California State University at Northridge. She has worked at every level of care, including outpatient, inpatient, and residential eating disorder programs as a primary therapist. Greta is an eating disorder consultant to many Southern California most highly respected drug and alcohol treatment programs, providing eating disorder education, staff training, and in-services. Greta has maintained a private practice in Beverly Hills for over 20 years. We are really very excited to have you both, and I thank you, and we're going to learn a lot.
Thank you, Renee. So excited to be in person. This is like a dream. I said, Greta, wow, I have my glasses. I can't even see. As almost 3 years have passed. Now I thought this would be my first talk with my reading glasses. Crazy, right? Welcome to getting older. So I think this is a really important topic because so many of you work in other areas and either don't know the questions to be able to ask your patients and appropriately screen. And Greta and I have found, in over 2 decades of doing this, our clients have oftentimes felt shamed and misunderstood. So we thought, this is a nice introduction to give you a little bit about when you really need to refer out and you are in over your head. So the way our workshop will be set up this morning is the following. We're going to discuss the criteria for different eating disorders and identify the most common ones in our culture. I think so often people perceive they're aware of what the most common eating disorders are, but we hope to clarify misconceptions you have centered around that. To identify the significant signs and symptoms of an eating disorder, again, we're touching upon warning signs that could fall through the cracks that you may or may not be aware of. Learning about the medical complications of eating disorders. This is very, very important because so often individuals will say, oh, my loved one will grow out of this, or it's just a phase, and you don't grow out of an eating disorder. It won't go away being on vacation or going in college. And being able to set up a solid team that is trained in eating disorders is really what we hope we can arm you with, understanding. Learning the difference between common disordered eating and the diagnosis of an actual eating disorder. It's been normalized in our society through diet culture to eat a certain way, and we feel shamed and judged and stigmatized if we don't eat this certain way or move a certain way or look a certain way that we have failed, which is all false. So we're going to talk about that. Learning how and why eating disorders are treated differently than substance abuse in the clinical setting. That's very important because I know from the years I ran groups at various sober livings, all the myths that float around in the sobriety community, and I know Greta has a lot to say about this. We really want to talk about what the gold standard is in the eating disorder field.
Good morning. So happy to be here also in person after all these years. So first we're going to start by examining the criteria for the different eating disorders that exist and identify the most common one in our culture. If you want to guess which one you think that is, just sort of tuck that away in your brain and we'll see if you're right. I'll start with anorexia nervosa, which is probably one of the most serious eating disorders, definitely the most fatal one. It's very complicated because of the medical issues that involve anorexia nervosa and the way that it literally changes your thinking. When I start working with a new patient, I educate them about what it's like. They already know what it's like to have anorexia nervosa, but to talk about how there's literally a voice inside of your brain that talks to you. It's not quite schizophrenia, but it's like these angel and devil on your shoulder, and it is constantly fighting within your brain, and it's really a miserable existence. And that thinking is extremely hard to change. It takes nutrition, psychotherapy, education, sometimes medication, and it takes a lot of time. So to be diagnosed with anorexia nervosa, you have to restrict your food intake, which will lead to weight loss. And you have to have an intense fear of weight gain or of becoming fat. So a lot of people will try to get better, but I don't want to gain weight. Well, that's not possible. We say in anorexia nervosa treatment that the food is the medicine. So sometimes you don't want to take your medicine when you're sick and it tastes yucky, but you have to. And you also have to have a distorted view of yourself, of what your body actually looks like. You will look in the mirror and see a different person than anyone else would see. There is a cognitive distortion happening in the brain. And you also have to not think that there is a problem. There are many high-functioning anorexics who have this disorder for 20 years, 30 years, 40 years. I've had 79-year-old women come to my office and say, okay, I'm ready to get better now. And unfortunately, we call those lifers. They have had the disorder since they were a teenager. Age of onset is between 13 to 17 years, and unfortunately, there are some people within that population who will never get better, who will succumb to their eating disorder and perhaps die. Bulimia nervosa is the next disorder, also very, very serious. Bulimia nervosa in terms of death is one of the scariest because with anorexia, it's a slow wasting away of the body. You can physically see someone's not okay. With bulimia nervosa, people look normal. They could be at an average weight, they could be in a larger body, a smaller body. You cannot tell by just looking at someone if they have bulimia nervosa. And the heart could actually stop in their sleep. And unfortunately, if you work in this field long enough, you will have patients who have died from a sudden heart attack, and I have experienced that sadly. So with bulimia nervosa, you must have binge eating, which is characterized by eating a large amount of food in a short period of time, and also feel like you cannot stop or control yourself when you're eating. Some patients will report feeling as if they're in a trance. They don't really understand the volume or the amount of what they're eating. Sometimes there'll be night eating syndrome, where they wake up in the middle of the night and go into the kitchen. They don't remember what happened until the morning when they see all the wrappers and the garbage in the kitchen. So as you can imagine, it's very difficult to treat this behavior. And you have to have a compensatory behavior after the binging, which is usually vomiting, but could also be using laxatives, diet pills, diuretics, colonics, fasting, and also over-exercising, which we'll touch on a bit later. And these behaviors are used to get rid of the food that you've just consumed and also to deal with the uncomfortable levels of fullness and also the psychological feelings that accompany this behavior. And you must do these behaviors for once a week for at least 3 months to be considered bulimia nervosa. So if you thought that binge eating disorder was the most common one, you're right. BED, binge eating disorder, is the most common one, also the newest one to be added to the DSM-5. And binge eating disorder is recurrent episodes of binge eating And they must include at least 3 of the following factors: eating rapidly, eating until you're uncomfortably full, eating when you're not hungry, eating alone out of embarrassment, and feeling disgusted, depressed, or guilty after eating. And these behaviors must occur 2 times a week for at least 6 months.
Just trying to see where I'm going to position myself here. So osfed, which is other specified feeding eating disorder. There's actually several criteria here. I'm going to actually move because I feel far away from the screen, so forgive me here. The glasses, right, so I can see. So atypical anorexia nervosa. So what I'd like to say about that is an individual that has atypical anorexia nervosa is an individual that could appear normal, look like they have a normal body shape and size. They could be in a larger body, but they struggle with the same problems that a person who looks emaciated or wasted. They're restricting, they have rigid food rules, the eating disorder voice is very loud and prevalent, and oftentimes these folks fall through the cracks when they're going to their healthcare provider's office. They're not taken seriously because, quote unquote, they don't look sick enough, which is all false, and they're in the same risk as a person who looks very ill. And this is something I find I'm constantly educating healthcare providers on, because they follow, unfortunately, the messages through diet culture and society versus realizing you can't look at a person and determine if they have an eating disorder or if they're sick. So I just wanted to comment on that. Pica, which I remember when I was a student, that was something that we first learned about. Basically, it's eating non-nutritive substances: clay, sand, paper, dirt. And people say, like, well, how come they would eat that? Well, oftentimes because they have nutritional deficiencies in their diet. Other times they could have something psychologically going on. It's seen with pregnant women, oftentimes eating those items I mentioned in addition to ice. But it's a way also, as I think about it, I have clients that are so afraid of food that this is what they've consumed to fill themselves up. And they've had their stomachs pumped time and time again because something gets caught and it's not meant to be consumed, essentially. I'm going to speak further down the road with diabolia, which we'll talk about, as well as exercise bulimia and orthorexia nervosa. So with ARFID, which is avoidant restricted food intake disorder, oftentimes the individual has a very limited intake. They've experienced some sort of potentially trauma in their life. They have a fear of choking. They are deeply afraid that they may not like it. It's affecting them psychologically. That, like, I have several kids I'm seeing now that their parents have kind of thrown their arms up because they haven't known how to work on the exposures, which we'll talk about, and really it ends up affecting them psychologically and oftentimes medically. Psychologically, from the standpoint that they don't eat with friends, they don't eat with family, they stop getting invited to events because of the fear of eating. And essentially, with many, the sensory issue is very relevant. So they may have, they could be on the spectrum, they have such deeply rooted fears of trying foods that either are not in these textures, these consistencies, and on the growth grid, I will just say, like, I have kids and adults, actually, when I think about the kids that have been steadily moving up and they've been consistent with their growth trends, eating the same 5 foods, but their families have gotten to a place of feeling frustrated of, I'd like to be able to broaden their nutritional regime. So it's really being able to have a team that understands how to work on the exposures and the introductions of this. Sensory issues, and it's interesting because it's not just with ARFID in other elements of their life. Maybe they're very sensitive to sound, they're very sensitive to light, they're highly sensitive people. But the sensory issue from something being too hot, something being too cold, I can't have it room temperature, there's too much crunching. I hear clients say, no, it bothers my ears if I have to chew that much, I need it to be smooth. It's really, I say my ARFID clients teach me the most, because I've never had one person be the same as another. They're all unique in their own right, and I think more and more pediatricians and providers are understanding this and being able to diagnose it and support it as well. Another big one is the fear of adversive consequences, choking, vomiting. Many of them have the fear of emetophobia. Like I have, one kid who's been in OCD therapy, watching emetophobia videos, and now he's actually not even afraid of vomiting anymore. It's really cool how the treatment has helped him be more receptive to different food choices. The choking, oftentimes it's derived from having some sort of trauma in their life, or from a very young age they remember choking on this specific food. And I think of one adult that I see that was never diagnosed with RFID, but he is an adult with RFID, and he's like, Robyn, I remember as a kid choking on the egg roll, and therefore I will not eat anything that, again, has texture, has multiple items mixed together. It's really interesting to hear the rationale and the reasoning, how individuals select the choices that they do. And the other part that is interesting, and this is the lack of interest or desire in food. Oftentimes their appetite is low. Food is just so scary and overwhelming and intense for them that the pleasure of eating has been completely abolished. As I was starting to speak about before on the growth grid, oftentimes there's folks who are consistently moving on the upward trend on their growth grid. But for times when the child is not moving up in height, weight, they're not based on how they've been historically within their growth grid, then their pediatrician might say, okay, there's something going on here, and that's when oftentimes they'll reach out to me, because their parents will say, well, my child hasn't grown for the last 2 years, and and I've actually one, as I'm thinking about now, who's upset that she never grew, and she's been a very petite person. Her parents are tall people, and I think oftentimes individual realizes later in life what damage has been caused. But the great news is that this completely can be reversible and changed by being able to address this. The other part is nutritional deficiencies. Oftentimes that doesn't come up until later. Like I have a 19-year-old I'm seeing now who has osteoporosis, and I remember when I had asked his dad to take him to get a DEXA, a bone density, he was like, oh, but he's a boy and he's 19, and it usually happens in older Caucasian women. I was like, no, I have clients that are young that have osteopenia, osteoporosis, and this could be a big factor. Or they might find, I'm losing chunks of hair, or I'm always cold because I have iron deficiency, I'm anemic. So I think a really savvy pediatrician is able to dig deep and see there is something going on versus just pushing it to the side. Oftentimes these individuals are requiring tube feedings. I personally have not had anyone in my practice that's been on a tube feeding for it. I know those of you that run treatment centers potentially have, but I know, the energy-dense supplements, I find a lot of the clients I see, especially with RFID, are not open to it because they'll say it's too sweet or it's too chalky or what have you. So then it's being able to create their own smoothie, shake, etc. But oftentimes this is the route that is incorporated. And the fear of being able to eat in public. Like, as I think of, one of the kids I see, finally, it's been like the last week, and it's amazing. He's able to go through a whole day staying at school, eating with lunch, connecting with friends, as opposed to oftentimes he has a panic attack because he can't be around the food. So being able to connect with people and not isolate and be lonely and have friends want to invite you out, especially you think about the last couple of years with COVID, that it's been such an isolating and lonely time, and all eating disorders thrive on that. So I have heard clients say to me, oh, I'm so glad, Robyn, restaurants are closed, I'm not invited out, and it hasn't affected me. And it's like people I know that have normal relationships with food are like, oh, I can't wait to go out again. Whereas my eating disorder clients are like, I'm afraid for the world to open up again because everybody's home and this has worked for me. And that's something to really understand as well.
Can I add something on ARFID? I just wanted to say that in terms of the treatment approach, ARFID actually utilizes a systematic, manualized, evidence-based approach. There's an actual workbook. It lines out exactly how many number of sessions, what you're supposed to do in each session. And that's normally not the case for eating disorder treatment, except for adolescent treatment. There's a system called FBT, family-based treatment, that's evidence-based, proven to be the best standard of care for treating adolescent eating disorders. But ARFID is the only one that really has that for anorexia and bulimia.
And the one last thing I'd like to add about it is, so ultimately it results in exposure therapy with various foods. So like I have one client who went with their mother to the store this last week, and it was just like to walk down the chip aisle. You don't have to buy the chips, but what about holding the bag of chips? Trying to envision what would it be like eating the chips. So we'll work on them actually building up to actually consuming the food. And it's just like, maybe it's touching a food, maybe it's helping a loved one stir the bowl with dinner. And that's a way to help a person be more receptive. And when the exposure therapy happens, it's always recommended it's in a safe space with a person that they feel comfortable with. And oftentimes with my younger clients that are going through RFED treatment, it is happening with the parents that they feel safe and comfortable with. So backtracking to the other eating disorder behaviors, I wanted to talk about diabolia. And this is typically seen in individuals that have type 1 diabetes that are on insulin. And the longer that a person is on insulin, their weight ultimately increases. So individuals are restricting their insulin dosing, and therefore their food intake could potentially be restricted or denied. And it's their way of purging, of avoiding the additional insulin. And unfortunately, that causes their glucose levels to spike and to drop. And I have a number of adults that are now classified as what's called, quote unquote, brittle diabetes, brittle diabetics, due to the years of abusing and restricting their insulin dosing. Exercise bulimia, I'm sure many of you know people that struggle with exercise bulimia. It's been definitely normalized in our society. I feel guilt, I'm gonna go run an extra 5 miles, I ate more at this meal, I gotta hop on my Peloton. There's so much shame in feeling fuller, being able to eat a food that feels shameful, that we're told we don't deserve to be eating, and if we eat this food, it will feel out of control. And it's really been something, it was just highlighted recently in the New York Times, an article on bigorexia, men that have the desire, and I see it with females, non-binary clients, the idea to consistently move themselves, but it's like, well, I want to be bigger, fitter, toned. It's like these unrealistic standards that have been set within society. So exercise bulimia, unfortunately, you could probably count on 2 hands or more how many people you know that use movement to relieve themselves and engage in these compulsory behaviors.
And if I can just add regarding that, exercise bulimia is hard to treat because exercise is normally viewed as a really positive behavior. Doctors tell you to increase your exercise normally. People have watches that tell them exactly how many steps they walk. And it's really something that's part of our culture, something that's encouraged and praised. And it's also an activity disorder. These people have a hard time sitting still. They need to be moving. And when you do run, for example, or do other types of cardio exercise, you do feel better. Your mood can feel better. So it's very complicated to try to tease out, what are the negative effects of it, what are the positive effects of it. And normally people will have to stop exercising completely and relearn how to have a healthy relationship with exercise and with their bodies.
Yes, I always like to say exercise bulimia is not what I would call joyful movement or intuitive movement. When I think of those terms, I think of as a kid running around on the playground and going on the monkey bars and, playing Twister and all these types of things that we do versus going on something that's telling me how many calories I'm burning and feeling like a hamster in a cage. That's not fun and pleasurable. So I think kind of looking at what type of movement really nurtures your soul and your mind and doesn't feel like something you, quote unquote, should be doing. And the last is orthorexia, another term that you're probably familiar with, or probably many people that suffer from it. It's the obsession to be healthy. It's taking health to an uber unhealthy place. It has to be organic, it has to be raw, it has to be keto, paleo, whole grain, whatever, all these food rules, and where a person is not able to be adaptable and flexible and eat in any circumstance based on the rigidity of the healthism.
And in orthorexia as well, again, something that's praised and encouraged. You're so good. You know, it's really something that has become normalized in our culture. The media loves talking about it. It's very, very hard to work with it, especially where we live, the city. I mean, there's a lot of diet culture here. It's everywhere you look. So very challenging to start to really teach people how to have a healthy relationship with food.
And I wanted to add, especially over COVID, where the anxiety and depression within our teens and college students has just escalated, the orthorexia has too, where it's sort of like, well, what can I control in my life? Well, I can control what I'm eating, how much I'm moving, and parents, people around will say, oh, I really admire your discipline. I really wish I could be like you, without realizing a bigger problem has developed. And I think with the calls I've received over these last 2.5 years, and I know the same with Greta and our other colleagues, is every call is a crisis, because the individual has fallen through the cracks and their families or their doctor hasn't realized there was an issue because they've been praised and acknowledged for that.
And just to let you know that dieting is the #1 behavior that does lead to an eating disorder.
Oh, sorry. And I wanted to just say sorry, and the illustrations are from my book that are in these slides, so I just wanted to let all of you know that.
So now we're going to talk about the significant signs and symptoms of these eating disorders. Some of them overlap, some of them are just specific to certain ones. So having a preoccupation with food or eating, like I said, that voice in your brain that is always telling you how much to eat, when not to eat, and that starts to take up so much time and energy in your brain that eventually people who seek treatment just say, I want to just stop thinking about food all the time. You will feel guilty after eating, perhaps disappearing right after a meal to purge, frequently comparing your body to other people's bodies, or even your body to your own body, the way it was from morning to night, from yesterday to today, weighing yourself 3 times a day. Well, weight fluctuates between 2 to 3 pounds on a given day, so that's a terrible thing to do actually when you are even dieting. Isolating from family and friends, eating alone or in your bedroom. You will have increased facial or body hair called lanugo that Robyn will touch upon when you have anorexia. Your hair may fall out, a lot of psychological problems with mood swings, a lot of co-occurring depression and anxiety, perfectionistic behavior, more in the anorexia profile, feeling cold often, and having swollen, puffy cheeks.
I just wanted to add, and an individual's hair might not fall out. It might be brittle, it might be drier, it might be thinning, it might not be growing. Those could be other signs too, and oftentimes an individual is aware of it because their hairdresser is telling them. They'll say, oh, isn't it because my hair is colored? It's like, no, okay, it's been the same for this time, but I think that's important to know that there's other factors too. It doesn't just have to be hairs falling out, and it could be, you're finding it in the shower, you're finding it on your pillowcase, so I think that's important to recognize too. Here we are. Okay, so lanugo, which is known as peach fuzz, we see this commonly on babies. When a person is malnourished, when they're restricting, they're in this, what I would call like this fight or flight syndrome. We see on the sides of their face, we see it on the front or the rear part of their shoulder. Another part we see it, which is not in this slide, is it could be in their lower back. And I have many, many clients that are getting waxing, laser hair removal. I thought I was just a hairy person. It's like, because they've been malnourished, their body goes into this what's called fight or flight syndrome. And the interesting thing is they're nutritionally rehabilitated, it goes away. It's like, how did that happen? And the other thing too I want to comment on, I don't know if there's a pointer on here. No? Okay. Well, no, it doesn't work. So in the picture of the shoulder, which shows muscle wasting, so in the what's called the somatic protein sores, when a person is wasted or emaciated, you'll see in their shoulders, you're like, oh wow, do I see their deltoids? No, you're seeing their bone, or you're seeing what's called temporal wasting, like in their temples, above their eyes, it becomes sunken, or jawline wasting. So this is all tied into the malnourishment, and it's seen with the lanugo. So lanugo, the peach fuzz, it's basically showing that a person is malnourished. Oh, my pointer, oh, they left.
I'll do it.
Thank you, it's not working. It's not.
Whoops.
Yeah, is it?
Sorry, there's something going on here.
My thing doesn't work. Hold on.
No.
Oh, nope. Let me go.
It's doing its own thing.
Hold on, sorry.
Okay.
Got it.
I'm not even touching
Okay,
it.
thank you. Sorry about that. Okay, thanks, Lynn. So, other factors, having headaches regularly. This is important to recognize because it could be their blood sugar's low, they're dehydrated, and if you go so long without eating, ultimately you're going to have this haze, and people say, well, I don't get headaches, but it's common that glucose levels rise, and also if you're not taking in fluid. The other thing I like to comment is individuals oftentimes use caffeine in place of food, therefore they're losing their electrolytes and they're becoming dehydrated, and that can cause a headache as well. Other signs, certainly diet talk to start out each day. We hear, oh, I'm going to be good, not eating such and such. A person's like bartering with themselves versus being able to treat the day as a normal day versus saying, oh, I'm not eating this or I'm not eating that. And so often these folks start out making deals with themselves and saying, well, okay, I'm not going to eat breakfast because at work today they're going to have the donuts or the bagels. It's like, versus learning how to pay attention to what our body's telling us. That's a far-fetched concept, but it is a reality and can happen. They also can avoid eating with certain people because they feel like that can be triggering or they're going to be judged, and oftentimes it's in their head. An individual's not going to judge them, but it's feeling insecure, like, well, I can't eat what I want or not eat because I'm going to be with these people. Another factor which I've seen too much over these last couple of years is individuals forcing themselves to move, even if they're injured, even if they're tired, even if they're sore, and to realize like injuries will happen and they can be long-term, they can be permanent, and it could set them back for a long, long time. And an individual just completely disregards how they're feeling and what their body's saying because that eating disorder voice has hijacked their mind. They judge people on what they're eating. I hear this all the time, like either, well, how can this person eat such and such? If I did, I wouldn't be able to stop. Or they'll feel like if I'm eating such and such, this person won't eat such and such. But as I always say to clients, the people you're eating with or people around you are not focused on what you're eating, what you're wearing, how you are. People are just excited to see you and connect with you versus, oh yes, Lynn had extra cheese on her sandwich. It's like, who cares? Good for Lynn for having cheese on her sandwich, extra cheese. Being able to meet people for coffee or tea, that's another one because there's no calories. I don't want anything that's going to have calories. And I think too, even with COVID, this has been normalized and trying to find other ways that don't incorporate meals. And I think to myself, like, I'm so excited to plan a meal with someone. It's like a breath of fresh air, all these new places, because a lot of my favorites have closed over these last couple of years as well. This is another factor too. An individual will only eat out if they know what's in the food or how it's prepared and how much fat or how much salt. I mean, it's like it's impossible. And also to think like, okay, this person's very rigid. There is a problem if they're not able to just say, okay, I'm going to go to whatever restaurant Stacy has selected for me. Most people that struggle with eating disorder are not able to approach. So, no, I'm okay at the moment. Thank you. I think it's okay right now. We'll see. Making excuses for canceling plans. Hearing this of, oh, something came up, I have something for work, versus I'll hear clients tell me, I've gone through my closet and nothing fits me. Nothing feels comfortable in my body. I don't want to have any kind of waistband on my belly. I feel so uncomfortable. I don't want anyone to see me in this outfit. It's like constantly making excuses why they can't connect and socialize with people. And I think too, even as a therapist or any type of provider, these are important questions to unpack and dig deep and ask, like, how come you cancel those plans? What concerns you about meeting that person? And really trying to explore on a deeper level. And as I said before, it's like they will not eat out with people. A lot of what I've found clients doing in these last couple of years is walking dates. Like, we're all walking, we're all trying to get out the house, but it's like, okay, how can you plan 5 walking dates a day? That's like a bit excessive. So I think understanding that as well.
I wanted to add, sometimes when people seek treatment, it's because they've experienced a bottom, like in substance or alcohol abuse, where they've just had an experience or a day that has finally made them realize they have a problem. When I used to work in treatment centers, we would have people write, what was your worst eating disorder day? And I recently had someone call me who was an executive and was traveling for work in New York City, had a big meeting that she was leading, and she just felt obsessed with having to know her weight that morning, and she didn't have a scale in her hotel room, and she rushed across town in New York City to go to her gym that she was a member of, in LA, to find a scale and weigh herself, and almost was late to the meeting. This is an intelligent, successful professional, and it was after she came back from that business trip that she realized, okay, I need to stop this.
Well, I'm glad that she realized that. Many people don't. So dangers of eating disorders, I mean, there's so many, and again, this is just touching upon it. Joint pain. So I'll hear clients say, like, well, I don't know why I have joint pain, I'm young. Well, because they've abused their body and they're not taking in enough nourishment, and they have problems walking, sitting, just daily activities of life, but where they're realizing, I have a problem because I'm in significant pain. Tooth damage and gum disease. So this could be through purging, the acid erosion, being able to look at gum disease. There's, a dentist friend of mine that I have educated more so about eating disorders, because oftentimes these folks fall through the cracks and the dentist will think, oh, okay, they have reflux, versus understanding the erosion that's been caused due to purging. And the other factor too is there's clients that regurgitate because they've purged so much, so that gag reflux is essentially like broken. And they have this additional acid overflow that's happened too, and that's affected their gum recession, their gum disease as well. A chronic sore throat, that's another big one. From purging, of course. I mean, I always ask my clients, like, have you ever purged blood? And it's like, oh, just a little bit. I mean, it's very dangerous, and we talk about could happen, but also with understanding the sore throat, people think like, oh, okay, now I'm not wearing my mask, that's why I have a sore throat. I mean, it's like they make excuses and justify, or because they consume so much caffeine and they're purging, the acid erosion is really significant, and again, just they have constant regurgitation. Dehydration. Of course, if a person purges, they're going to be dehydrated. Their sodium, their potassium, their phosphorus, their magnesium, their electrolytes are off, but in addition to the person that chronically consumes caffeine, that's taking their body out of their baseline level of electrolyte balance. And we don't think about dehydration as being a dangerous sign of an eating disorder, but a person could collapse, they could be disoriented. And this whole electrolyte imbalance with weakness and fatigue, I mean, I can see one of the things that clients always get mad at me for is when we're talking about, like when I'm taking their vitals, when I want to be able to work on getting their pulse to be loud and apparent versus very quiet, blood pressure as well, and I talk about working in electrolytes, and they'll say, oh, I'll just buy vitamin water. I'm like, no, I need electrolytes that have calories. So when I'm talking about Gatorade, I always start with Gatorade or Powerade, but unfortunately, many of these clients also have orthorexia, and it's like, no, it's not natural, it's not pure. So I'm like, okay, what about coconut water then? Because it's the same thing, and okay, I'll have the coconut water. They feel like, okay, I'm a little more wholesome than that. And there's other forms too that are basically like candies that I talk about too, but this is a big factor, especially when an individual constantly has a delayed thought process, they're losing their thoughts, and really understanding how to not be like from lying down to standing up. I'm not seeing stars or flashing. That's a big thing. Or my client was telling me the other day he was bending down to tie his shoe and he got up and he lost his balance. And this is someone who is in his 20s. It's like, yes, because you're constantly dehydrated and your electrolytes are off. Irregular heart rates and rhythm, arrhythmias. If a person, again, is not getting a sufficient amount of nutrition, their heart is stressed out and working overtime. And one of the problems is people don't realize they could develop arrhythmia problems, especially when they're consuming high amounts of caffeine, and not just coffee, teas, but Monster drinks and Red Bulls and these very high concentrated caffeinated sources. And it's like, well, I don't need to eat because I'm having that. I mean, I have a client who's a performer and she collapsed on stage because she's drinking these drinks all day long and now has heart issues, and she's in her early 30s. We don't think about the rupture of the heart or the esophagus. And I will just say, with these clients being this sick, like my friend Renee, who's here from Acute, and some of others that have medical stabilization programs, this is where these clients need to go because they're not appropriate for residential. They're the sickest of the sick to be able to get medically stabilized. Shortness of breath. This is huge. It could be I'm just walking to my car and I'm out of breath, or walking down the hall. And this is why we discourage when their vitals are off, their electrolytes are off, not to be able to do any kind of activity that elevates their heart rate. And clients, like, I think one of the problems is when a parent will overstep what the provider's recommendation is and say, like, just happened with a client, and the parent's like, oh yeah, you can go to the gym. I know it helps your mental health, but your child could have a heart attack or develop a heart issue. And I think that's a problem too, when you have a family member that's colluding with the disease as opposed to following the recommendations from the treatment team. I thought you were going to say something. Chest pain. Another factor, again, you don't have to be an older person. You can be a younger person to experience chest pain as well. And sometimes the anxiety and the panic attacks can, instigate this, or you might say, well, which happened first? But it does happen, as well as having abnormal EKG, ECG, inverted T waves. Basically, if a person has their EKG done, you're not having these inverted T waves. Basically, the electrical system in your heart is not working the way it's required to. And cardiac arrest can happen, and the research shows 1 out of 3 people survive a heart attack. And I can tell you because my father passed away of one, and I was in cardiology, so I understand that statistic very well. And loss of menstruation. So if you're a cisgender female who does menstruate, and people say, well, I'm on an IUD, I'm on the pill. Well, it doesn't give a true assessment of what your body is truly capable of doing. So that's important to understand too.
That's actually a hard one when women come to us and I will ask them, can you please get off your birth control? Because that is a natural gauge we can use to determine if your body is at a healthy weight. It's not the only thing that means you're not underweight anymore, but it is at least some data point that we can use.
Also, fainting. I feel like this happens more times than we realize, and I have a number of clients that were found places. I'm actually seeing someone later today that doesn't even remember and had collapsed somewhere and just woke up in the bed at Cedars-Sinai and ends up, had been abusing caffeine and Coors Light beers. So between being dehydrated, having a very low sodium level, just being a mess, could faint and collapse. That could also include difficulty breathing. We think about like, oh, I'm just having a panic attack. It's like, no, you're not taking in enough nourishment, so therefore every breath you take is hard work on your heart and your organs. Dizzy and blackouts, which I think kind of goes with the fainting. I mean, I have another client, she's like, I was told that I blacked out, but I saw the video that my husband took of me at this dinner party. I mean, it's amazing how I'll speak to someone the way I could speak to any of you, and individuals have no recollection. They're like, if there wasn't videoed, I think someone was making it up. So delayed capillary refill time, which I'm going to talk about shortly, that's something I do with everyone in person to be able to see how fast their blood return happens, and I'll talk about that shortly. And I will just say over COVID, became very creative on Zoom with how to do this with people, which I'll talk about shortly. Memory. Memory is a big one with like, well, I don't remember what I was studying or what I was reading or who I was speaking to or what my thought process was. And sometimes it's like, well, I have so many things I'm thinking about. It's like when you're not taking in enough nourishment, your brain is slow. It's like a slow-mo movie. So therefore, you're not going to be quick and precise in being able to respond and recall what your thought process was. Sleeping difficulties. This is a very important one. I always like to educate all the psychiatrists on this as well, because I hear clients say, oh, I'm going to the psychiatrist and I'm going to go on sleeping medication. Well, when you're not taking in enough nourishment, an individual either has a difficult time falling asleep, sleeping through the night, or sleeping in the next day. So they will have interrupted sleep and wake up countless times throughout the night. And as they increase their intake, they are able to have better sleep. And the thing is, too, is with a lot of these folks, and we'll talk about, and I actually, I don't know if I have it on this slide. Oh, perfect. The cold sweats. So I always ask clients about nighttime sweats or cold sweats, like you're feeling like, oh, my neck, my pajamas, my shirt is a little like, perspired. So what I describe is this is very dangerous. When you've not had enough at dinner or an evening snack, your blood sugar drops. So I always evaluate my clients' legs. I mean, they're taking their shoes off. I mean, I'm literally like checking them out. And so with their lower extremities, it's often that an individual will be bruised all in here, because with having low blood sugar, when you're having these nighttime sweats, in your sleep, if someone were to video you, the heel of the foot would be banging against that shin area, and an individual could develop an epileptic seizure. So this is the other reason that we encourage, and I talk about when I'm working on helping someone be nutritionally rehabilitated, that they are having a nighttime snack. That's a whole other topic to discuss, because it's like, no, I don't want to eat after dinner. I'm only eating, it's like you need food, which is why your blood sugar level has dropped. And that's very important to understand severity, because people will say, oh yes, I bang into things all the time. It's like, maybe, but no, when a person's lacking nutrition, it's a reoccurring pattern, or they have bruises that don't heal as well. Another factor is a person, that experiences trauma, cutting, scratching, self-harm, burning. We've seen a lot of self-harm in these last couple of years. That's really escalated as well, and that's another danger of an eating disorder, as well as death. We don't realize how many clients do die and are at risk every time, like throwing the dice, like will they be here, will they not? It's really, I always like to say, if you take me to Las Vegas, I will not gamble because I don't like to lose money, but I only bet when I know I'm right. And in certain cases, I'll tell clients, like, this is what's going to happen. And fear for many is what brings them into our offices. So the capillary refill time, and I always like to do this with clients. So I have them squeeze their fists for 10 seconds. We do this together, and they open. I do, and like if you see on mine, like my red in my hand, my blood flow, the return happens fast. And with these clients, you see that it stays white, pale, their fingertips are very cold. We assess it in the tops of their feet or in their fingertips. So the capillary refill time is something, as I was saying, I did it over Zoom, more times than I realize. There's nothing like seeing a person in person that you can see their skin tone and be able to really assess what's going on with them. And the other factor, too, I don't know if it was already in your slide, but I will just say, for those clients that purge, oftentimes their parotid glands are very swollen. It's like chipmunk cheeks, because from the purging, they're not able to have the saliva, but it gets backed up. So these are factors just to look at if you're sitting with your client. And the thing with Zoom is like, oh, I'm sitting from here up. It's different when you're seeing them in person. So really just trying to take note on what they're sharing to you and what you can physically see. And always, if you have questions, can always reach out, but I think it's important to be able to just have that awareness versus saying, oh, this is how the person looks. They've always had these full cheeks, and that's not the case.
So unfortunately, Robyn just talked about all these really, really serious and scary things that can happen when somebody has a serious eating disorder. To this day, eating disorders are not taught in medical school, which is just crazy to me. Adolescent medicine is the only medical specialty that mandates a training in eating disorders. So anyone who has not done the adolescent medicine rotation will know nothing about eating disorders, will not even understand how to read the labs. I have to have Robyn read the labs. Robyn actually, I have to say this, is above and beyond one of the best dietitians in the country. She shadowed an eating disorder physician in Texas. There's also very few of those, by the way, because eating disorders are not taught in medical school. You have to just decide you want to specialize in this population and get on-the-job training with your patients. I will have to have Robyn read the labs because the doctor doesn't even understand what kind of labs to order, what they're looking for, and it's a very sad state, in our community. And also, because of this, doctors sometimes make the situation worse. People who go for an ear infection don't need to be weighed. And being weighed and getting your blood pressure taken is just an automatic thing that happens when the nurse sees you before the doctor comes in. So we have to call ahead. We have to figure out who's going to be weighing our patient, either tell them to not weigh our patient. Robyn and I both have medical scales in our offices that we use. But sometimes they'll have to be weighed backwards. Don't write the number down on a yellow Post-it and leave it on the counter. So, and they still don't listen. We call, they say, sure, but then the day gets crazy, there's 100 patients in the waiting room, and they just forget. So unfortunately, there's a delay in diagnosis. There's misdiagnosis. These disorders can last for years without the doctor ever really understanding what's going on. So the psychological underlying issues of eating disorders is very, very important to understand because eating disorders are not just about being thin and looking good. 100 people can go on a diet, but one will develop a serious eating disorder for a variety of reasons. There are some genetic dispositions. Michael Strober here at UCLA has done great research about anxiety and how they haven't identified the actual gene. There's no money in the research funding, but there is a correlation with genetics. A first-degree family member will often have had an eating disorder. But these psychological underlying issues, eating disorders are coping skills. Just like drug and alcohol addiction, gambling, sex, shopping, they are used to cope with feelings, to numb feelings with food or with exercise. You could have certain family dynamics in your childhood that can predispose you to an eating disorder. Wanting to feel special, accomplished, powerful. You get so much attention. If you're a child in a family with an eating disorder, the whole family revolves around you all of a sudden. The other siblings just kind of get pushed to the side, and everybody has to come in for 2 to 3 times a week therapy, seeing the dietitian, seeing the doctor, seeing the psychiatrist. You can't go on vacation anymore because your kid won't eat anything. You have to pull your kid out of school, maybe homeschool the kid, pay tens of thousands of dollars for treatment. This is such an expensive disorder to have. And, it's very important to understand all the psychological issues that underlie these disorders. So this is really where I think a clinician who doesn't work with eating disorders should stop. When it's disordered eating is someone who diets, maybe talks about food a little bit too much, but their nutrition hasn't been compromised. They don't have these medical issues that Robyn spoke about. It's not their entire life, but they might have food rules or altered food beliefs. And again, this is so glorified in our culture. Almost everyone I know has some form of disordered eating. It's complicated, and it's hard to have really a healthy relationship with food in our culture. So in my opinion, disordered eating is kind of where a non-ED clinician should really stop and refer out after that. So to think that it really has to significantly impair your life. They've stopped going to school, it's hard to work, they have a hard time focusing. If even one of the medical issues is present, it's gone too far. I would refer out at that point. So this is a controversial issue, actually, because there is a major, major philosophical difference when you treat someone in the substance abuse setting versus treating somebody who has an eating disorder. And these disorders can co-occur. So many, many times I get a referral from somebody who is at a substance abuse treatment program, they're living in their sober living, but they're coming to me for the eating disorder treatment. And I use different language. I use a different philosophy. People with eating disorders can be recovered with a period on the end. People in substance and alcohol addiction, they are in recovery forever. They utilize the steps, they go to their meetings, they have a sponsor, they have to stop going to the bar every day after work, they have to change their friends sometimes. You can't do that with food. You have to coexist with food, 3 meals a day, hopefully 2 snacks. Food is something that should be enjoyed, celebrated. A lot of our celebrations and family wonderful moments take place around the dinner table. So it's a very, very different way to treat eating disorders. And there's also controversy about sugar, abstaining from sugar. There are some treatment programs that tell people you can't have sugar. Your brain is addicted to it. Eating disorder clinicians don't feel this way. We use the intuitive eating model, which is Elise Resch, Evelyn Tribbley, 2 incredible pioneering dietitians from Southern California, wrote this book. It is the Bible that we all use in our field. And it talks about how all foods fit. All foods are okay. There's no good or bad foods. Foods don't have feelings. Everything breaks down into glucose at the end of the day. And that is not the language that a lot of these substance abuse programs use. Also, the concept of health at every size, another very important philosophy and treatment approach. All bodies are okay. If you are in a larger body, that doesn't necessarily mean you're not healthy. Your lab work, your heart, your organs can function just as well, if not better, than someone in an average size body or smaller body. And sometimes you have to have certain furniture in your office to really understand that you're treating all types of people and all types of bodies, and to not engage in weight stigma. Thank you so much. It was such a pleasure to speak with you, and we hope you learned a lot.
I just want to point out these are our references. My book, The Eating Disorder Trap, your recovery resource, which is an online course I have for parents, partners, and caregivers. It's on my website, which we'll talk about. Sick Enough by Dr. Jennifer Gaudiani. The 8 Keys to Recovery by Carolyn Costin and Gwen Grab. The 4th edition of Intuitive Eating. This is my book, The Eating Disorder Trap. It is on Amazon and everywhere that it can be found. Our online course, your recovery resource. It's 35 modules for parents, partners, clinicians. It's been great. My colleague Becca Clegg and I created this, who's an eating disorder therapist in Atlanta, and we created a coupon code for everyone here at the conference today. A person can do it at their own pace. There's videos, handouts. It's something that really lacks in the eating disorder field. And then here are Greta and I for any other questions, comments that you guys have as well.
Sometimes OCD, a lot of those spectrums, major depression sometimes occur, that other than the treatment for the illness, maybe there's a broader spectrum that needs to be addressed.
Yes.
The underlying anxiety.
Yes, you're absolutely right, and there also are very few psychiatrists who understand this population, and we work with the best of the best. So if you email us or contact us privately, we'll give you some names.
How many times when you see a person, or per caseload, if you have 10 people, how many of those patients would actually see psychiatrists?
The majority. The majority. With anorexia, you have to restore their weight first. The medication won't work if they're so malnutritioned, but it's very, very common to be on an SSRI or another type of medication, yes.
I mean, I think that's definitely a form of pica, but it looks like there's the self-harm part too, with like, you know, cutting the esophagus, the throat. I mean, that looks like there's, you know, I would definitely have a psych eval if it hasn't been done already, because it sounds like it's taking pica to an oomph level, but that's roll the dice too. Has that been assessed on him?
Yes, he's in a psychiatric hospital.
Yeah.
RTC before.
You can come ask him lots of questions afterwards here. Yes, and so thank you very much.
Thank you.